So now we are going to discuss acute bronchitis. Now, acute means that there is basically, symptoms that start suddenly and for a short time period, and the inflammation of bronchi are called the bronchitis. Now, this is usually viral, and the patient is going to be afebrile. So there is no fever. It's usually viral. It comes as like a cough that is productive and purulent sputum after a recent URTI. So your patient is going to have an upper respiratory tract infection, and then after that you have purulent sputum, but patient is afebrile. So this is basically after that you have a viral infection. Now in this there is epithelial sloughing that can make sputum look yellow and purulent, and it's not a sign of bacterial infection. So it is just like a fake thing that you might think it's bacteria because it's a purulent sputum, yellowish kind of, but that yellow color is coming from the epithelial sloughing. Now, this can also be blood tinged due to erosion of small vessels from inflammation and the epithelial damage, but it's not alarming. Now, there could also be mild wheezing that reflects the airway involvement and the rhonchi that improve with cough. So, you will ask your patient to cough, and that rhonchi is going to be improved. That suggests that these secretions can easily be mobilized. Now, on a chest X-ray, what are you going to see? A clear lung, because it's not very bad, and so we only treat it with supportive care. Now, no further evaluation is needed for small volume, new onset blood, and no risk factors for malignancy or bronchiectasis. Now, bronchiectasis is highly associated with recurrent infections. So, if your patient has, small volume, no signs of bronchiectasis or malignancy, we can just, have no further evaluation. Now, recurrent bleeding, high risk of malignancy, and abnormal chest X-ray, or stable patient but active bleeding estimated to be more than 30 ml requires HRCT. So you should always know what is the indication of HRCT. We were doing no further evaluation usually, but HRCT suspect malignancy or abnormal X-ray or a stable patient with more than 30 ml of bleeding. Now let's talk about cough. Now cough is divided into three categories actually. There is acute cough, which is less than 3 weeks. There is subacute cough, which is 3 to 8 weeks. And then there's chronic cough, which is more than 8 weeks. This is very important to remember. Now, suspected etiology on history and physical exam. Now, you should know that you can evaluate and treat as indicated. Like if there is ACE inhibitor usage, you can stop the ACE. If there is, you suspect this is upper airway, cough, you can use first generation H1 blocker. If it's asthma, you do PFTs. If it's good, then you treat empirically with a PPI. Now, if there's no improvement after the interventions, 2 to 3 weeks, then you perform a chest X-ray. Okay, so in case you, on the history and physical exam, you think it's a parenchymal disease or a purulent sputum is there, the patient's either immunocompromised or there's no specific etiology, then you directly do a chest X-ray, but you have to rule out all of these things first. Now, in case of, common etiologies that are associated with chronic cough, you should know the upper airway cough syndrome with a postnasal drip is a very common thing. Then asthmas and cough variant asthmas, GERD and laryngopharyngeal refluxes can also cause cough. Post-respiratory tract infections, ACE inhibitors, chronic bronchitis, chronic sinusitis, bronchiectasis, lung cancer, and non-asthmatic eosinophilic bronchitis can do that as well. Now, chronic cough, I told you that it is more than 8 weeks, and usually it is associated with three most common things: upper airway cough syndrome with postnasal drip, GERD, or asthma. Three things always remember. So it is the UACS, GERD, or asthma. Now, upper airway cough syndrome can occur after a recent infection, and cough occurs at night, caused by chronic rhinosinusitis conditions, which include allergic and the perennial non-allergic and vasomotor rhinitis, acute nasopharyngitis, or sinusitis. Now, diagnostic confirmations and treatment is that there's improvement of the nasal discharge in cough with first generation H1 blockers, antihistamines. Now, what is included in first generation antihistamines? It's chlorpheniramine or combination of antihistamine and a decongestant like brompheniramine or pseudoephedrine. So A simple thing is, if you have a patient with upper airway cuff syndrome, you give chlorpheniramine or brompheniramine or pseudoephedrine. Okay, a combination of congestant as well. Then we basically have another thing called as intranasal azilastine. It's a topical antihistamine, and it's a first-line treatment option for vasomotor rhinitis. In addition to blocking H1 histamine receptors, azilastine also stabilizes the mast cells. So it prevents the eosinophil activation, inhibits the pro-inflammatory cytokine production, thereby relieving the symptoms of rhinorrhea and nasal congestions of the vasomotor rhinitis. So this patient should also be encouraged to avoid the known triggers, that can include NSAIDs or strong odors like perfume. Intranasal glucocorticoids, fluticasone are further first-line treatment options for this. Saline nasal irrigation and nasal decongestants like pseudoephedrine can also be added as adjuvant therapy. So even I have one of the patient I know personally who has vasomotor rhinitis, and it's a very severe kind of rhinitis that happens because of the triggers. Now, non-allergic and allergic rhinitis. Let's talk about this. Now, we all know allergic rhinitis, right? So the allergic rhinitis patients, usually we see that these have watery rhinorrhea and sneezing and eye symptoms. And they have an earlier onset because allergies are usually early in the childhood exhibited, and there is an identifiable allergen or a kind of a seasonal pattern to it. And their mucosa, very important, is the mucosas of the patients with the allergic type kind of rhinitis have the either pale or bluish nasal mucosa, and it's associated with other allergic conditions like eczema or asthma or eustachian dysfunction. So treatment is simple: intranasal glucocorticoids or antihistamines. These are the two things you give, or either nasal glucocorticoids or antihistamines. What about non-allergic rhinitis? So they have nasal congestion, they have rhinorrhea, they have sneezing, and they have post-nasal drainage. But there's a later onset of these symptoms, more than 20 usually. There's no obvious allergic trigger, but there are perennial symptoms, may worsen with season changes. And they have erythematous nasal mucosa. So this is a very important difference between the allergics and non-allergics. The non-allergics have erythematous nasal mucosa, whereas allergics have the pale blue nasal mucosa. The treatment is similar for both the kinds of rhinitis, which is again intranasal antihistamine or glucocorticoids, and for a moderate to severe, there is combination therapies. Now, we talked about vasomotor rhinitis. The second name is the non-allergic rhinitis, and its diagnosis is usually very clinical diagnosis. Routine allergy testing is not necessary prior to an empiric therapy, which is almost a similar empiric therapy. Now, plain radiographs of performance symptoms can suggest a chronic sinusitis. Now, patients with prominent rhinorrhea and a postnasal drip, which is dry coughs, and sometimes respond to first-generation antihistamines, chlorpheniramine, but rarely responds to antihistamines without the anticholinergic properties like loratadine. Loratadine is a second-generation antihistamine. So we prefer first-generation, which is chlorpheniramine. Now, topical intranasal antihistamines, azilastine or olopatadine. So these are very important ones, olopatadine and azilastine. Now, let's talk about ventilator settings. Now, in ventilator, there are few measures that we have to take care of, like PaCO2 and PaO2. Now, PaO2 is a measure of oxygenation, and what is it going to be influenced by two factors: the FiO2, which is fractional oxygen saturation, and the PEEP. The PEEP. Okay. Now, the PaCO2 is basically the measure of ventilation, and this is affected by respiratory rate and tidal volume. Very important. Now, normal FiO2 at sea level is 0.21 or 21%. Another very important MCQ usually comes that this is a normal FiO2 level, so that's 0.21 or 21%. Now, patients are often provided a high FiO2, which is 80% or 0.8 initially in a mechanical ventilation pending the result of the first ABGs. So you will send ABGs, but you will start your patient on an FiO2 of 0.8. Now ventilator setting can then be changed based on the results of the ABG. Now goal is your partial pressure of oxygen should be more than 60. Now an important early goal in initial ventilator management should be able to decrease the FiO2 to non-toxic values, and and no strict cutoff of FiO2 values for oxygen toxicity, but levels below 50 to 60 are desirable. We always want that our FiO2 levels are less than 60. We don't want to make it more than 60. So a decreased FiO2 when PaO2 is increased. Eventually, when if we are achieving our oxygen, the PaO2, then we are going to decrease this FiO2 and add PEEP if adequate oxygenation is not achieved with high FiO2. Now, assist control mode of mechanical ventilation delivers a predetermined tidal volume with every breath. So, you should know that in mechanical ventilation, we have different modes. So, assist control mode specifically has a predetermined tidal volume. Now, inspiratory cycles can be initiated by the patient, but if the patient fails to breathe at a set minimum rate, then the ventilator will deliver the tidal volume on its own. Now, it means that, assist is that the patient, can try their own breathing pattern, but if they fail, the ventilator is going to assist them. Now, a normal tidal volume, you should know it is the 6 ml per kg of the ideal body weight. Okay, so it's 6 ml per kg. Now, in patients with ARDS, the mechanical ventilation improves oxygenation by providing increased fraction of inspired oxygen and by providing PEEP to prevent the alveolar collapse. When FiO2 is decreased below 60%, PEEP can be increased to maintain the adequate oxygenation in patients with ARDS. Now, if respiratory alkalosis, which means pH is more, the PaCO2 is less, and the PaO2 is more, develops at an appropriate tidal volume being delivered, then respiratory rate should be lowered. Reduction in tidal volume can trigger an increased ventilatory rate, and there can be exacerbation of situation. Okay.